Hi, today we will be discussing Chapter 30 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of hearing. The function of the external and middle ear is to amplify sound to facilitate conversion of the mechanical energy of the sound wave into an electrical signal by the inner ear hair cells, a process called mechanotransduction. Sound waves enter the external auditory canal and set the tympanic membrane or eardrum in motion, which in turn moves the malleus, incus, and stapes of the middle ear. Movement of the plate of the stapes causes pressure changes in the fluid-filled inner ear, eliciting a traveling wave in the basilar membrane of the cochlea. The tympanic membrane and the ossicular chain in the middle ear serve as an impedance matching mechanism, improving the efficiency of energy transfer from air to the fluid-filled inner ear. Within the cochlea of the inner ear, there are two types of hair cells that aid in hearing: inner and outer. The inner and outer hair cells of the organ of Corti have different innervation patterns, but both are mechanoreceptors. They detect the mechanical energy of the acoustical signal and aid its conversion to an electrical signal that travels by the auditory nerve. The afferent innervation relates principally to the inner hair cells, while the efferent innervation relates principally to the outer hair cells. The outer hair cells outnumber the inner hair cells by nearly 6:1. The motility of the outer hair cells alters the micromechanics of the inner hair cells, creating a cochlear amplifier, which explains the exquisite sensitivity and frequency selectivity of the cochlea. Stereocilia of the hair cells of the organ of Corti, which rests on the basilar membrane, are in contact with the tectorial membrane and are deformed by the traveling wave. A point of maximal displacement of the basilar membrane is determined by the frequency of the stimulating tone. High-frequency tones cause maximal displacement of the basilar membrane near the base of the cochlea, whereas low-frequency sounds, the point of maximal displacement is toward the apex of the cochlea. Hearing loss can result from disorders of the auricle, external auditory canal, middle ear, inner ear, or central auditory pathways. In general, lesions in the auricle, external auditory canal, or middle ear that impede the transmission of sound from the external environment to the inner ear cause conductive hearing loss, whereas lesions that impair mechanotransduction in the inner ear or transmission of the electrical signal along the eighth nerve to the brain causes sensory neural hearing loss. The external ear, the external auditory canal, and the middle ear apparatus are designed to collect and amplify sound and efficiently transfer the mechanical energy of the sound wave to the fluid-filled cochlea. Factors that obstruct the transmission of sound or dampen the acoustical energy result in conductive hearing loss, and they can occur in the following situation. Eustachian tube dysfunction is extremely common in adults and may predispose to acute otitis media or serous otitis media. Trauma, acute otitis media, and chronic otitis media are the usual factors responsible for tympanic membrane perforation. While small perforations often heal spontaneously, large defects usually require surgical intervention. Tympanoplasty is highly effective in more than 90% in the repair of tympanic membrane perforations. Otoscopy is usually sufficient to diagnose acute otitis media, serous otitis media, chronic otitis media, cerumen impaction, tympanic membrane perforation, and eustachian tube dysfunction. Tympanometry can be useful to confirm the clinical suspicion of these conditions. Cholesteatoma, a benign tumor composed of stratified squamous epithelium in the middle ear, or mastoid, occurs frequently in adults. This is a slowly growing lesion that destroys bone and normal ear tissue. A chronically draining ear that fails to respond to appropriate antibiotic therapy should raise suspicion of cholesteatoma. On examination, there is often a perforation of the tympanic membrane filled with cheesy white squamous debris. The presence of an oral polyp obscuring the tympanic membrane is also highly suggestive of an underlying cholesteatoma. Conductive hearing loss secondary to ossicular erosion is common. Bony destruction visualized on computerized tomography of the temporal bone is highly suggestive of cholesteatoma. Surgery is required to remove this destructive process and reconstruct the ossicles. Conductive hearing loss with a normal ear canal and intact tympanic membrane suggests either ossicular pathology or the presence of the third window in the inner ear. Fixation of the stapes from otosclerosis is a common cause of low-frequency conductive hearing loss. It occurs equally in men and women and is inherited as an autosomal dominant trait with incomplete penetrance. In some cases, it may be a manifestation of osteogenesis imperfecta. Hearing impairment usually presents between the late teens and the 40s, and in women, the otosclerotic process is accelerated during pregnancy. A hearing aid or a simple outpatient surgical procedure, a stapedectomy, can provide excellent auditory rehabilitation. Disorders that lead to the formation of a pathologic third window in the inner ear can be associated with hearing loss. There are normally two major openings or windows that connect the inner ear with the middle ear and serve as conduits for transmission of sound. These are the oval and round windows. The third window is formed where the normally hard otic bone surrounding the inner ear is eroded. Dissipation of the acoustic energy at the third window is responsible for the inner ear conductive hearing loss. The superior semicircular canal dehiscence syndrome, resulting from erosion of the otic bone over the superior circular canal, can present with conductive hearing loss that mimics otosclerosis. Common symptom is vertigo evoked by sounds, by Valsalva maneuvers that change middle ear pressure, or by applying positive pressure on the tragus. Patients with this syndrome also complain of fullness of the ear, pulsatile tinnitus, and being able to hear the movement of their eyes and neck. A large jugular bulb or jugular bulb diverticulum can create a third window by eroding into the vestibular aqueduct or posterior semicircular canal. The symptoms are similar to those of the superior semicircular canal dehiscence syndrome. Low activation threshold on the vestibular evoked myogenic potential test and inner ear erosion on CT are diagnostic. Recalcitrant vertigo, dizziness may respond to surgical repair of the dehiscence. Sensory neural hearing loss can result from either damage to the mechanotransduction apparatus of the cochlea or disruption of the electrical conduction pathway from the inner ear to the brain. Thus, injury to hair cells, supporting cells, auditory neurons, or the central auditory pathway can cause sensory neural hearing loss. Damage to the hair cells of the organ of Corti may be caused by the following. Congenital malformations of the inner ear may be the cause of hearing loss in some adults. Genetic predisposition alone or in concert with environmental exposures may also be responsible. Exposure to loud noise, either a short burst or over a more prolonged period of time, can lead to noise-induced hearing loss. Acute exposure to noise can lead to either temporary or permanent threshold shifts depending on the intensity and duration of sound, due to hair cell injury and/or death. More recently, loud noise exposure has also been associated with hidden hearing loss. Hidden because routine audiometric tests show the pure tone hearing to be normal. Patients usually complain of not being able to hear clearly and are more bothered by the presence of background noise. In contrast to hair cell loss, hidden hearing loss is thought to be due to loss of auditory synapses on hair cells following noise exposure. Presbycusis is the most common cause of sensorineural hearing loss in adults. In the early stages, it is characterized by symmetric, gentle to sharply sloping high-frequency hearing loss. With progression, the hearing loss involves all frequencies. More importantly, the hearing impairment is associated with significant loss in clarity. There is a loss of discrimination of phonemes, recruitment, and particular difficulty in understanding speech in noisy environments, such as at restaurants and social events. Poor hearing is also associated with an increased incidence of cognitive impairment and rate of cognitive decline. In the elderly left untreated, hearing loss leads to diminished quality of life and has been shown to increase overall morbidity and mortality. Hearing aids are helpful in enhancing the signal to noise ratio by amplifying sounds that are close to the listener. Cochlear implants are the treatment of choice when hearing aids prove inadequate, even when hearing loss is incomplete. Meniere's disease is characterized by episodic vertigo, fluctuating sensory neural hearing loss, tinnitus, and aural fullness. Histologically, there is distension of the endolymphatic system or endolymphatic hydrops, leading to degeneration of vestibular and cochlear hair cells. This may result from endolymphatic sac dysfunction secondary to infection, trauma, autoimmune disease, inflammatory causes, or tumor. An idiopathic etiology constitutes the largest category and is most accurately referred to as Meniere's disease. Typically, low-frequency, unilateral sensory neural hearing impairment is present. Magnetic resonance imaging should be obtained to exclude retrocochlear pathologies such as cerebellopontine angle tumor or demyelinating disorder. Therapy is directed toward the control of vertigo. A 2 gram per day low-salt diet is the mainstay of treatment for control of rotatory vertigo. Diuretics, a short course of oral glucocorticoids, intratympanic glucocorticoids, or intratympanic gentamicin may also be useful adjuncts in recalcitrant cases. Surgical therapy of vertigo is reserved for unresponsive cases and includes endolymphatic sac decompression, labyrinthectomy, and vestibular nerve section. Sensory neural hearing loss may also result from any neoplastic, vascular, demyelinating, infectious, or degenerative disease or trauma affecting the central auditory pathways. Hearing loss can accompany hereditary sensory motor neuropathies and inherited disorders of myelin. Tumors of the cerebellopontine angle, such as vestibular schwannoma and meningioma, usually present with asymmetric sensory neural hearing loss with greater deterioration of speech understanding than pure tone hearing. Multiple sclerosis may present with acute unilateral or bilateral hearing loss. Typically, pure tone testing remains relatively stable while speech understanding fluctuates. Isolated labyrinthine infarction can present with acute hearing loss and vertigo due to cerebrovascular accident involving the posterior circulation, usually the anterior inferior cerebellar artery. It may also be the heralding sign of impending catastrophic basilar artery infarction. A finding of conductive and sensory neural hearing loss in combination is termed mixed hearing loss. Mixed hearing loss can result in the following conditions. The goals in the evaluation of a patient with auditory complaints is to determine the nature of the hearing impairment, the severity of the hearing impairment, the anatomy of the impairment, and the etiology. Presence of signs and symptoms associated with hearing loss should be ascertained. The history should elicit characteristics of the hearing loss, including the duration of deafness, unilateral versus bilateral involvement, nature of onset, and rate of progression. Other associated symptoms and pertinent history should be obtained. A sudden onset of unilateral hearing loss with or without tinnitus may represent a viral infection of the inner ear, vestibular schwannoma, or a stroke. Patients usually complain of reduced hearing, poor sound localization, and difficulty hearing clearly in the presence of background noise. Gradual progression of a hearing deficit is common with otosclerosis, noise-induced hearing loss, vestibular schwannoma, or Meniere's disease. Small vestibular schwannomas typically present with asymmetric hearing impairment, tinnitus, and imbalance. Cranial neuropathy, in particular of the trigeminal or facial nerve, may accompany large tumors. Meniere's disease may be associated with episodic vertigo, tinnitus, and oral fullness. Hearing loss with otorrhea is most likely due to chronic otitis media or cholesteatoma. Examination should include the auricle, external ear canal, and tympanic membrane. In examining the eardrum, the topography of the tympanic membrane is more important than the presence or absence of the light reflex. Insufflation of the ear canal is necessary to assess tympanic membrane mobility and compliance. Careful inspection of the nose, nasopharynx, and upper respiratory tract is important. Unilateral serous effusion or unexplained otalgia should prompt a fiber optic examination of the nasopharynx and larynx to exclude neoplasms. Cranial nerves should be evaluated with special attention to facial and trigeminal nerves, which are commonly affected with tumors involving the cerebellopontine angle. The Rine and Weber tuning fork tests are used to screen for hearing loss, differentiate conductive from sensory neural hearing loss, and confirm the findings of audiologic evaluation. The Rine test compares the ability to hear by air conduction with the ability to hear by bone conduction. The tines of a vibrating tunic fork are held near the opening of the external auditory canal, and then the stem is placed on the mastoid process. The patient is asked to indicate whether the tone is louder by air conduction or bone conduction. Normally, and in the presence of sensory neural hearing loss, a tone is heard louder by air conduction than by bone conduction. With conductive hearing loss of more than or equal to 30 decibels, the bone conduction stimulus is perceived as louder than the air conduction stimulus. For the Weber test, the stem of a vibrating tuning fork is placed on the head in the midline. The patient is asked whether the tone is heard in both ears or better in one ear than in the other. With a unilateral conductive hearing loss, the tone is perceived in the affected ear. With a unilateral sensory neural hearing loss, the tone is perceived in the unaffected ear. A 5 decibel difference in hearing between the two ears is required for lateralization. The minimum audiologic assessment for hearing loss should include the following tests. This test battery provides a screening evaluation of the entire auditory system and allows one to determine whether further differentiation of a sensory cochlear from a neural retrocochlear hearing loss is indicated. Other tests to assess hearing include evoked responses and imaging studies. Pure tone audiometry assesses hearing acuity for pure tones. It establishes the presence and severity of hearing impairment, unilateral versus bilateral involvement, and the type of hearing loss. An audiogram is a plot of intensity in decibels of hearing threshold versus frequency. Conductive hearing loss, with a large mass component, as is often seen in middle ear effusions, produce elevation of thresholds that predominate in the higher frequencies. Conductive hearing losses with large stiffness component, as in fixation of the footplate of the stapes in early otosclerosis, produce threshold elevations in the lower frequencies. Often, the conductive hearing loss involves all frequencies, suggesting involvement of both stiffness and mass. In general, sensory neural hearing loss, such as presbycusis, affect higher frequencies more than lower frequencies. An exception is Meniere's disease, which is characteristically associated with low-frequency sensory neural hearing loss. Noise-induced hearing loss has an unusual pattern of hearing impairment in which the loss at 4,000 Hz is greater than at higher frequencies. Vestibular schwannomas characteristically affect the higher frequency, but any pattern of hearing loss can be observed. Speech recognition requires greater synchronous neural firing than is necessary for appreciation of pure tones. Speech audiometry tests the clarity with which one hears. The speech reception threshold is defined as the intensity at which speech is recognized as a meaningful symbol. It is obtained by presenting two-syllable words with an equal accent on each syllable. An individual with normal hearing or conductive hearing loss can repeat 88 to 100% of the phonetically balanced words correctly. Patients with a sensory neural hearing loss have variable loss of discrimination. As a general rule, neural lesions produce greater deficits in discrimination than do cochlear lesions. Tympanometry measures the impedance of the middle ear to sound and is useful in diagnosis of middle ear effusions. A tympanogram is the graphic representation of change in impedance or compliance as the pressure in the ear canal is changed. Normally, the middle ear is most compliant at atmospheric pressure. With normal hearing or in the presence of sensory neural hearing loss, the compliance decreases as the pressure is increased or decreased. Compliance that does not change with change in pressure suggests middle ear effusion. With a negative pressure in the middle ear, as with eustachian tube obstruction, the point of maximal compliance occurs with negative pressure in the ear canal. A tympanogram in which no point of maximal compliance can be obtained is most commonly seen with discontinuity of the ossicular chain. A reduction in the maximal compliance peak can be seen in otosclerosis. The presence or absence of the acoustic reflex is important in determining the etiology of hearing loss as well as in the anatomic location of facial nerve paralysis. It can help differentiate between conductive hearing loss due to otosclerosis and that caused by an inner ear third window. It is absent in otosclerosis and present in inner ear conductive hearing loss. Normal or elevated acoustic reflex thresholds in an individual with sensory neural hearing impairment suggests a cochlear hearing loss. An absent acoustic reflex in the setting of sensory neural hearing loss is not helpful in localizing the site of lesion. Assessment of acoustic reflex decay helps differentiate sensory from neural hearing loss. In neural hearing loss, such as with vestibular schwannoma, the reflex adapts or decays with time. Autoacoustic emissions are generated by outer hair cells and can only be measured with microphones inserted into the external auditory canal. The emissions may be spontaneous or evoked with sound stimulation. The presence of OAEs indicate that the outer hair cells of the organ of Corti are intact and can be used to assess auditory thresholds and to distinguish sensory from neural hearing loss. Electrocochleography measures the earliest evoked potentials generated in the cochlea and the auditory nerve. Clinically, the test is useful in the diagnosis of Meniere's disease, in which an elevation of the ratio of summating potential to action potential is seen. Brainstem auditory evoked responses are useful in differentiating the site of sensory neural hearing loss. They are valuable in situations in which patients cannot or will not give reliable voluntary thresholds. They are also used to assess the integrity of the auditory nerve and brainstem in various clinical situations, including intraoperative monitoring and in determination of brain death. Vestibular evoked myogenic potential test investigates otolith and vestibular nerve function by presenting a high-level acoustic stimuli, and evoking a short latency electromyographic potential. CVEMP or OVEMP have been described. CVEMP is a biphasic short latency response recorded from the tonically contracted sternocleidomastoid muscle in response to loud auditory clicks or tones. It may be diminished or absent in patients with early and late Meniere's disease, vestibular neuritis, benign paroxysmal positional vertigo, and vestibular schwannoma. The threshold for VEMPs may be lower in cases of superior canal dehiscence, other inner ear dehiscence, and perilymphatic fistula. The OVEMP, in contrast, is a response involving the utricle primarily and superior vestibular nerve. The OVEMP excitatory response is recorded from the extraocular muscle and is abnormal in superior vestibular neuritis. The choice of radiologic tests is largely determined by whether the goal is to evaluate the bony anatomy of the external, middle, and inner ear, or to image the auditory nerve and brain. Axial and coronal CT of the temporal bone is ideal for determining the caliber of the external auditory canal, integrity of the ossicular chain, and presence of middle ear or mastoid disease. It can also detect inner ear malformations. CT is also ideal for the detection of bone erosion with chronic otitis media and cholesteatoma. MRI is superior to CT for imaging of retrocochlear pathology such as vestibular schwannoma, meningioma, other lesions of the cerebellopontine angle, demyelinating lesions of the brainstem, and brain tumors. Both CT and MRI are equally capable of identifying inner ear malformations and assessing cochlear patency for preoperative evaluation of patients for cochlear implantation. Conductive hearing loss associated with atresia can be addressed with a bone anchoring hearing aid. Tympanic membrane perforations due to chronic otitis media or trauma can be repaired with an outpatient tympanoplasty. Conductive hearing loss associated with otosclerosis can be treated by stapedectomy, which is successful in more than 95% of cases. Hearing aids are effective and well tolerated in patients with conductive hearing loss. Patients with mild, moderate, and severe sensory neural hearing losses are regularly rehabilitated with hearing aids of varying configuration and strength. In the event that the hearing aid provides inadequate rehabilitation, cochlear implants may be appropriate. They are neural prostheses that convert sound energy to electrical energy and can be used to stimulate the auditory division of the eighth nerve directly. For individuals who have had both eighth nerves destroyed by trauma or bilateral vestibular schwannomas, brainstem auditory implants placed near the cochlear nucleus may provide auditory rehabilitation. Tinnitus often accompanies hearing loss. Patients with tinnitus should be advised to minimize caffeine ingestion, avoid high doses of non-steroidal anti-inflammatory drugs, and reduce stress. Relief of the tinnitus may be obtained by masking it with background music. Hearing aids are also helpful in tinnitus suppression, as tinnitus maskers, devices that present a sound to the affected ear that is more pleasant to listen than tinnitus. Antidepressants have also been shown to be beneficial in helping patients cope with tinnitus. Conductive hearing loss may be prevented by prompt antibiotic therapy of adequate duration for acute otitis media and by ventilation of the middle ear with tympanostomy tubes in middle ear effusions lasting more than 12 weeks. Loss of vestibular function and deafness due to aminoglycoside antibiotics can largely be prevented by careful monitoring of serum peak and trough levels. Noise-induced hearing loss can be prevented by avoidance of exposure to loud noise or by regular use of ear plugs or fluid-filled earmuffs to attenuate intense sound. This ends this slide set on disorders of hearing.